Hello, ladies and gentlemen. Thank you for joining us for another webinar from the Brain Aneurysm Foundation. Our guest tonight is Dr. Andrew Ringer. He is a neurosurgeon, dually trained both in endovascular and microsurgical treatment of brain aneurysms from Mayfield Brain and Spine. He's also chief of neurosurgery at Good Samaritan Hospital, which is the major cerebrovascular center.
Evening. Thanks for the introduction. As Aaron just got through saying, I am Andy Ringer. I'm cerebrovascular neurosurgeon and director of cerebrovascular neurosurgery for Mayfield Clinic, as well as the chief of neurosciences at the Tri-Health Hospital System and director of neurosurgery for Good Samaritan Hospital. I wanted to talk to you about some of the various different outcomes that we see after aneurysm treatment and focus more specifically on cognitive outcomes, including memory, cognition, and decision making. As a point of disclosure, here we go. I do provide some consulting services, although I've not received significant payments from any of the companies mentioned above. And I'm an active participant in the collaborative research group known as the Endovascular Neurosurgery Research Group, many of which members have contributed to this talk significantly. So I want to give my thanks to those members as well. Also, as a point of clarification, it's important to note I am also human. So just like you, I can get sick. And somehow today I came down with some sort of nasty bug. So if you're squeamish, just be forewarned, there will be sneezing and probably blowing of noses. So I just hope that doesn't bug anybody. When patients with unruptured aneurysms are looking to make decisions about their treatment, they're faced with a lot of very complicated pieces of information and decision-making processes that include, for example, who with an aneurysm is at risk for rupture, what are the treatments that are available to me, and who should be treated and who should not be treated. And these decisions can become very complicated. As many of you may be aware, much of the decision-making as to when we treat unruptured aneurysms has in part to do with the size of the aneurysm and its location on the circulation in the brain, where we recognize that smaller aneurysms are less risky than larger aneurysms, and aneurysms on the arteries feeding the front of the brain appear to be less risky than those on the arteries feeding the back of the brain. But that is not it. That's not the whole story. Obviously, there's also the decision then, if you want to have treatment, what is the better treatment for you? And in large part, there are two major categories of treatment options available, including open surgical craniotomy for clipping of aneurysms and X-ray guided or endovascular inside the artery approaches, commonly known as coiling, and sometimes using other devices for treatment of those aneurysms as well. Each of these treatments may have their own advantages and disadvantages, and I don't necessarily want to spend a lot of time on this because we want to get to the more important topic we wanted to talk about today, such as cognition and memory. Surgical treatment of aneurysms is the likelihood that there will be a lifetime cure for many of these aneurysms, that once clipped and proven occluded in the operating room, there's virtually a 95% lifetime guarantee you would never see any part of that aneurysm again, even if you look for it, and a 99% lifetime guarantee that it wouldn't bleed, which is about as close as you can get to a guarantee in medicine. On the other hand, there are studies that show that the upfront risk of new disabilities after open surgical treatment for aneurysms may be a bit higher than for the endovascular approaches. And in some studies, those disabilities, depending on how you measure them, can be quite high, particularly for our older patients over the age of 65. When looking at endovascular options, the advantages here are sometimes obvious. The less invasive approach, the quicker, easier recovery for patients returning back to their normal activities. But the disadvantages are that the 95% lifetime guarantee for most surgical treatments turns down to a 85 or 80% lifetime guarantee, because occasionally the blood pulsating against those coils treats the coils like garbage in a garbage compactor, pushes them into the aneurysm further, and may open up an empty space at the base of the aneurysm. As a result, we typically require follow-up studies and imaging studies for our patients with coils just to ensure this isn't happening to you. Now, the third option is to not treat the aneurysm at all. This has an obvious advantage in that you're not undergoing any risky treatments. There is no recovery time. You simply go on about your normal business. The risk that you take is the natural history risk of that aneurysm and knowing whether or not it might rupture in your lifetime. In many cases, I want to stress, this risk might be quite low, and this is a very reasonable option for many, many patients. But the decision-making when we're trying to assess these risks and trying to compare and quantify these risks is changing. As the treatments of aneurysms is maturing, as more and more devices are becoming available, making treatment safer, we're seeing fewer strokes, faster recovery, better outcomes, and it becomes very important to know what exactly will affect that patient with the treatment. And this is what we wanted to focus on tonight. Most studies looking at the quality of outcomes after aneurysm treatments looked at what we consider now somewhat outdated or perhaps more rudimentary outcome scales. Many of them did not look at things like cognition, memory, or cognitive function as an outcome. And in fact, many of these patients who were previously considered under old studies to have had very good outcomes might in fact not be able to perform their normal daily activities or return to their work because of their cognitive disabilities. This is the modified Rankin Scale. This is a very commonly used outcome scale for the reporting of outcomes after cerebrovascular disease treatment. And as you can see, this goes from 0 to 6 with increasing levels of disability as a consequence of the disease or the treatment. It doesn't matter which. And by and large, typically we consider a good outcome to be anything better than number 3. Number 3 is, you see, the first level at which you need some help to do all of your normal activities. So 0, 1, and 2 are often lumped together as a good outcome. However, several studies, and for many years, clinicians have recognized that some of the patients that we would otherwise describe as having a good outcome are in fact disabled. That is, they can't do the job they used to do. They may find it difficult to balance the checkbook, to run their household, to keep track of chores. They just simply can't function in the way they used to, and it is entirely because of cognitive disabilities. What are these cognitive disabilities that can occur for patients with aneurysms or with aneurysm treatment? Well, they may include many things such as difficulties with attention and concentration, loss of their visual spatial skills, that is kind of understanding the relationship of physical objects in space, perceptual or cognitive problems, and the list goes on, as you can see on the slide in front of you. And any of these things can cause rather significant difficulties with performing normal daily activities. So how does this kind of cognitive injury occur? Well, in general, we consider there may be 3 main categories of causes. One is, does the aneurysm rupture? The other is, there may be risk factors that produce aneurysms or increase the likelihood of having aneurysms that are also associated with the development of cognitive disabilities because of other cerebrovascular diseases. And finally, if an aneurysm is treated, there may be some risk of this type of cognitive loss as a consequence of the treatment itself. So if you look at these individually, how aneurysm rupture causes cognitive disability is kind of easy to understand. It is a very deadly disease. About 40% of people who rupture their aneurysm will die as a consequence of that hemorrhage. And among the people who survive, many, if not most, may survive with some level of permanent disability. And that might be as a consequence of the stroke from the hemorrhage, with paralysis, walking difficulties, vision loss, or it could be cognitive disabilities, or both. Now, how about those patients who have an aneurysm that hasn't been treated but hasn't ruptured? How do they get cognitive disabilities? Well, one group looked at this in detail, looking back at a series of other studies that have reported cognitive outcomes in patients with aneurysms, and they recognized that even patients with unbled or unruptured aneurysms seem to have more cognitive disabilities than patients without aneurysms. And this may be in large part because of the risk factors for aneurysms that also sometimes cause cognitive disabilities. And what they identified was a general trend over time for our patients with unbled aneurysms. They are the dotted line that you see in the graph here compared to the normal population without aneurysms in the solid line. These patients with unruptured aneurysms may show some slow, gradual cognitive decline. They get a little bit worse when they undergo treatment, but usually recover from the treatment effect, but not back to where the normal population is. They go back to their previous level of disability. That is, they never quite reach back to the level of function seen in patients who don't have aneurysms. And finally, there may be risk associated with the treatments. One study, which was designed primarily to look at the risk of hemorrhage from an untreated aneurysm, also tracked patients who did get treatment. So keep in mind, this is not a comparative study between surgery or coiling, but rather just an observation of what happened to patients who did get aneurysms treated. And you'll see on the graph here that at both 1 year, at 3 years and at 1 year, 30 days and 1 year, sorry about that they looked at overall disability using the modified Rankin, just like the scale that we showed you, and cognitive disability through cognitive testing. And I want to draw your attention to the lines here highlighted in yellow. These are patients who only had cognitive disability. That is, under the modified Rankin Scale score, they would have been considered a good outcome. And yet you can see that somewhere around 5 to 7%, that's 1 out of 15 or 17 people, had disability only because of cognitive effects of the treatment of their aneurysm. So the Endovascular Neurosurgery Research Group, which is a collaborative looking at the outcomes for all cerebrovascular disease and in particular aneurysms, has had a particular interest in reporting these outcomes. And among the members is Aditya Pandey at the University of Michigan. He and his partners took a very deep dive into the cognitive outcomes of patients with treatment of an unruptured aneurysm. They wanted to look at 40 patients who had aneurysm coiling, 40 that had aneurysm clipping, and 40 other patients who didn't have an aneurysm or any aneurysm treatment to serve as normal controls. They wanted to look at a series of different endpoints or time points during their recovery to see when they might have recovery from their disability. And they noted in their patient population a fairly typical pattern of complications that might occur as a result of the treatment. You see here having temporary seizures or a wound infection, injury of the nerves around the base of the brain that may help, for example, move your eyes, raise your eyelid, for example. These are not necessarily disabling complications. And likewise, the endovascular procedures, which didn't have any of those problems associated with the surgical approach, or the only procedures that had potential for injury to the arteries. These are pretty typical outcomes, pretty typical complication rates. And in fact, these are quite good outcomes. Very good, very low complication rates for aneurysm treatment. They put together a series of very detailed cognitive tests to look at how the patients were performing with regards to their memory, their word recognition, their decision-making, their analytical skills, all of these things. So they did, for example, the auditory verbal learning test, which is, as you can see in the description on the slide, a test in which you're given a series of 15 words. You work at it until you memorize it, but then they give you a trick set. They give you an extra set of 15 words and ask you to go back and remember the very first one. Try not to get confused with the second test. They show you a very complex figure for your visual spatial memory of different shapes and patterns and lines, and then they take the picture away and ask you to draw it from memory. They want to see how closely you can do it. They also looked at their manual dexterity. So each of their patients was given this pegboard, and you'll notice that the wings on the pegs, or the holes for the pegs, are in different directions for each of the holes. You're required with one hand to pick up the pegs and fit them into the holes, and they time you to see how quickly you can do it. You have to do it with both your right and your left hand, so it doesn't matter which hand is dominant for you. And then they try to give you a series of words, color words that are in colors, and you'll notice that the word yellow is not in yellow, the word black is not in black, etc. And they try to trick you. So they'll ask you, for example, only read the words that are in black. They'll also ask you to name as many words as you can think that start with the letter N, for example. And this is all about recognizing patterns and how you can come up with these patterns on your own. And then as far as processing speed, this is the rate at which you can recognize patterns and make decisions. They might give you a series of numbers or letters and numbers and ask you to trace them in order or alternating order between letter and number, for example, A, then 1, B, then 2, C, then 3, etc., and see how quickly and accurately you can trace out that pattern. And then finally, this is a rather complex decision-making or analytical tool in which numbers are replaced with symbols, and you need to use the symbols with the key to perform simple arithmetic and things of that nature. So as you can see, these are very detailed tests that were done to assess the cognitive abilities of these patients who had undergone aneurysm treatment. And here's what they found. When you look specifically at memory, I don't want you to look at these graphs and think that one line above the other means they're better. What's more important is the change over time. That's what's really important here. So you will notice that the normal patients got a little better at the test, probably because they'd practiced it and gotten used to it. The patients who had coiling really didn't get any better at first. They maybe got just a smidge worse, but the surgical patients, right away after surgery, just 2 weeks later, were noticeably worse in their memory scores, but recovered around 3 to 6 months later. Likewise, if you look at fine motor skills, both the normal patients, the non-treated patients, I should say, and the coiled patients got a little better by practicing the test. Surgical patients, a little bit worse at first, but again, recovered that function within about 3 to 6 months. And then when you look at executive function and processing speed, this was perhaps the most notable change where the surgical patients had the biggest hit in their level of function. But once again, were able to recover back to their baseline in about 3 to 6 months after the procedure. Now, some people have argued that specific aneurysms may be at greater risk for cognitive injury than other aneurysms, in particular when surgical exposure is required to treat them. And one of those is the anterior communicating artery, or the ACOM. This is towards the front, between the two halves of your brain in the front, and the frontal lobes are often very important for some of these cognitive functions. So you'll notice that in this cohort of patients, that in the surgical arm, there was a higher rate or higher likelihood of having treated ACOM aneurysms than for the coiling group. So they wanted to look at their surgical patients and see, did the ACOM aneurysm patients do worse than the other clipped aneurysms? And when they look at this, when you look specifically at just memory functions, they were really pretty similar. Each group took a little bit of a hit right after surgery and again recovered within about 3 to 6 months. But with regards to the motor function, that is that fine motor skill testing, and with the processing speed or executive function, the ACOM aneurysm patients did take a little bit more of a hit. That is, they did a little worse on that testing early after surgery than the non-ACOM aneurysm clipping patients. That is, they all had surgery, but some of them for that one location and others for the other locations. However, both groups seem to show good recovery after 3 to 6 months. So in their conclusions, they identified that patients who had microsurgical clipping of their aneurysms were a little bit more likely to have some disability with regards to their short-term memory, their processing speed, and perhaps their fine motor skills right away after surgery. But typically that disability recovered within 3 to 6 months. Now, that kind of detailed testing tells a big story, and it can be very important information for making a decision about what treatment option might be better for you. But those are a lot of really detailed tests, and after all, who has time for all of that? The office schedules where patients are evaluated and seen by their physicians and the nurses are very busy places. The schedules are packed. The physicians and the nurses have very limited time, and after all, our patients do have lives. They have to get out of the office, they have work to go back to, they have kids in school, they have errands to run. So you can't spend hours and hours doing this kind of testing on every single patient. So there are other tests available, such as the Montreal Cognitive Assessment Test, which is a standard battery of tests designed to look at many of the same functions with the exception of the fine motor skills, and to do this for reporting through a scored mechanism to see what your level of function may be. A higher score means you're doing better. And some of the members of Energy, the Endovascular Neurosurgery Research Group, have taken this test and tried to make it a more standardized way of evaluating cognitive outcomes. For example, Dr. Rob James at the University of Louisville is performing in a National Institutes of Health sponsored trial known as ASTRO, looking at ways to mitigate the effects of vasospasm, a secondary effect of aneurysm rupture, against their poor outcomes, both stroke rates and on cognitive outcomes. So each of his patients is being assessed by this tool, and they're recording cognitive outcomes for a prospective randomized government-funded trial. Several other members of Energy are also making this part of their standard practice and are doing so for the purpose of collecting data on not just aneurysm patients, but other cerebrovascular patients as well, and making it available for reporting. We hope through their efforts and the efforts of others in the group, we'll be able to report cognitive outcomes for our aneurysm patients in the very near future. In fact, one of those members, Dr. Clem Schirmer at Geisinger Health, has taken this a step further, where in his group, he's recognized that the risk of cognitive outcomes and perhaps the cognitive outcomes themselves can influence the satisfaction that the patient has with the decision-making process. Dr. Schirmer has recognized that the decision-making process, whether or not to treat an aneurysm and how to treat it, can be very complicated. It involves many factors that may be objective factors, such as the age and gender and health status of the patient, some subjective patterns, such as the reasons that the patients may or may not want to have treatment, and other healthcare delivery factors, such as what's available in their community, what is the experience of the treating physician, what are the biases in that community. And what he's recognized is that there may be several different outcomes when you look at what the physician, the treating physician, and the patient expect or want out of their treatment. You might see that both the physician and the patient feel the aneurysm should be treated, and so they'll be in agreement. They may both agree that the aneurysm should not be treated and be very much in agreement there. But there are times when the physician and the patient may not agree on observation versus treatment of an aneurysm, and this creates some discordance, some dissatisfaction, and perhaps it may be that the information wasn't adequately shared with the patient, or that the outcomes or potential effects of treatment weren't fully understood. So Dr. Schirmer and his group have looked at a number of standardized scales that are designed to help understand how patients are coming to the decisions that they have for their healthcare treatment. One of them is the SURE test, which is a scale designed to answer the question, how sure were you that you made the right decision about what your treatment should be? How did you feel that you had the information that you needed? Did you feel that you had the tools that were necessary to make a good, educated decision? He also looks after treatment at something called the regret scale score. This, as you might guess, is a survey designed to determine whether or not the patient regrets the decision they made, or if they're happy with the decision that they made about their treatment or observation. Excuse me. Dr. Schirmer has been following data and collecting data on these outcomes for many patients, and with a couple of interesting findings. First and foremost, I just want to point this out as a point that we've brought up before, that while the modified Rankin Scale, as it increases, that is, as your disability increases using the old outcome scale scores, so does often the cognitive status. But you'll notice that even patients who have a normal or good modified Rankin of 0, 1, or 2, many of them do also have some cognitive disability. This is something that would have been unrecognized under previous outcomes reporting. What Dr. Schirmer also recognized was that patients who had worse outcomes with regards to their cognitive skills, that is, lower scores on the MoCA test, were not only less likely to be sure about whether or not they had the right information to make their decision, but were also a little bit more likely to regret their decision. This may not be entirely surprising, but it might be that the patients were not fully informed, or didn't at least feel fully informed about the potential for these outcomes. And finally, he looked at whether or not the patients were satisfied with the use of the MoCA score for assessment of their cognitive outcomes. And again, as you might expect, patients who performed poorly in the test were a little bit less likely to be satisfied with the testing. The Endovascular Neurosurgery Research Group is looking at a lot of this data and looking at the processes that are used to track cognitive outcomes after cerebrovascular care. And these are very dedicated physicians who are trying to make these kinds of outcomes more standard with regards to reporting of the outcomes for aneurysm treatment as well as other disorders. So let's switch gears here a little bit, and let's talk a little bit about what you can do to help mitigate some of these problems or help to improve your cognitive function. Whether you have an aneurysm, have had an aneurysm that was treated, or observing one, or have a loved one that's in one of those situations, any of these things may be helpful. First and foremost, let's talk about controlling the risk factors for cognitive disability from vascular disease. This not only may influence whether or not you have an aneurysm, but even in the absence of that, whether or not you may suffer some of these cognitive declines that we described earlier. There are several risk factors that we recognize as being quite important. Among them include smoking. Without question, smoking is the greatest risk factor for vascular disease, including what we call microvascular dementia. High blood pressure can also be a significant risk factor for any of these things, including forming an aneurysm, rupturing an aneurysm, or having cognitive dementia. And alcohol use is an influence. Now, moderate alcohol use is considered okay. In fact, it might actually be good for you. But moderate means between 1 and 2 glasses a day, but no more. And 1 or 2 servings of alcohol has to be defined. It doesn't mean that big mug that they serve you in the bar down the street. One serving of beer is 12 ounces of beer. A serving of wine is 5 ounces of wine. That means there are 5 glasses, not 4 glasses, in a bottle of wine, and 1.5 ounce of 80 proof liquor. If what you're drinking is 120 proof, guess what? It's only 1 ounce. So you have to keep track of what you're drinking and know the volumes that count for a particular serving. And if you can control these risk factors, you will decrease your risk of having an aneurysm. If you have one, decrease the risk of rupturing it. And whether you do or not, it will improve the likelihood that you maintain your cognitive function. Other things to consider is what you eat. There's actually been research done recently on cognitive outcomes and maintenance of cognitive function based on nutrition. And what has become recommended in a very large study done recently is what we call the MIND diet. It's kind of an acronym based on a combination of the Mediterranean diet and the diet for ischemic and nutritional defense mechanisms. And this, as you can imagine, is much like what is often considered the heart-healthy diet. The 10 brain-friendly foods that have been identified as better for cognitive outcomes are listed here above. Just to quickly go over them: green leafy vegetables, non-starchy vegetables, berries, in particular strawberries or dark blueberries, nuts, olive oils, whole grains, fish, beans, poultry, and wine in moderation. Remember, just 1 or 2 glasses a day. But you should limit your exposure to foods like butter or margarine, cheese, largely because of its fat content, red meat, fried food, sweets, and pastries. So keep this list in mind. Even if you don't measure portions, knowing that what you're eating is something that's good for you is a big step towards maintaining your cognitive function. And finally, get regular exercise. There's a lot of data out there showing that people who are regular exercisers are much less likely to have cognitive decline as they age than those patients who are inactive. In fact, one study looked at patients for over a 25-year period. And they looked at patients who were exercisers. They kept track of their fitness. They actually put them through a fitness test, identified those patients that had greater levels of fitness, followed them for 20 years, checked their cognitive function, and then did it again 5 years later. And what they found is the patients who were in better shape did better on the cognitive function tests than the patients who were in less good physical condition. So regular exercise, probably through improving brain blood flow, will help to improve your cognitive outcomes as well. So I hope this has been helpful. I hope this will let you know that there are things you can do to help improve your cognitive outcomes. There are recognized risk factors for outcomes after aneurysm and aneurysm treatment, and that there's a lot of ongoing research, including that done by the Endovascular Neurosurgery Research Group, to try to help improve those outcomes and make us all more aware of them. Thanks so much for participating with the webinar tonight, and we hope that you've gotten some really good, useful information out of it. Thanks again to the Brain Aneurysm Foundation for sponsoring this and for all the work that you do in supporting those who suffer from brain aneurysms and their loved ones. Good night.